All right. Types of shock. Turn it over. Don't look at it. Don't turn. Oh, okay. I'm going to walk you through. I know. Yeah. Okay. Sorry, I thought it said types. No, it's going to get really mad. Okay. So we're going to walk through every single shock from top to bottom. Let's hit it, shall we? Treatment, everything, bada boom. Yeah, let's do it. All right. So we're going to start with hypovolemic shock. How did we get here? Dehydration. You ran out of fluid. Trauma. Surgery. Bleeding. Dehydration. Which means your blood pressure went?
No.
It did go down. And so your body said, oh, something's wrong. You're going to continue to leak more into the third space. First signs and symptoms of hypovolemic shock. Be careful with this one. First.
Tachycardia.
Right. So we're going to compensate first. Remember, y'all got to think about each of these. We're going to go through the stages too. Yeah.
Yes.
So they'll have tachycardia, but hypotension. Yes. They may start to breathe a little faster. Right. Okay. And they're going to try to compensate. Okay. You may see somewhat of a decrease urine output, but it's still probably going to be within the realms of normal unless we go into like severe. Yes. Okay. So at the beginning, that's what we're going to see. A. At this point, if I did a CBC, what would that look like? I did not say what type of shock they had. I'm just looking for, we're just talking hypovolemic, huh?
Hemoconcentration.
Yes. Very good. Hemoconcentration, which means what will I see in the CBC? Increased hematocrit, right? Because hematocrit just tells us red blood cells to water. Since you have less water, it's going to make it appear as if you have a lot, right? But do you have a lot of red blood cells? No, you just have less water. Got it? All right. Blood pressure is going to be, okay, you're going to start to see as we start to progress, you will start to see what happening to the urine output. It's going to decrease. That is called oliguria. Very good. All right. So then your body at this point is going to have to start making some choices. It's going to pull away from what signs and symptoms will you have when it pulls away from extremities?
Increased
Signs of poor perfusion, increased cap refill, modeling, weak pulses, cold extremities. Yeah, because it's shunting all the blood to central. Yeah. Okay. But at this point, you're going to have body's trying to do what the body can do to compensate. Yeah. Okay. You think they're going to feel a little nervous? Yeah. Probably have some anxiety, and we're not getting full cerebral perfusion. So they may have a little bit of like, like a little confusion, just kind of like, what, you know? Yeah. Okay. What would happen to their preload? It would go down because preload is the amount, or sorry, the stretch in the left ventricles. Thank you. Good job. You have been redeemed. All right. So what's the first thing I'm going to do for this patient? Fluids, and then pressors if we need it. Yes. Yeah. Okay. What labs are you going to draw on a hypovolemic patient that's going into hypovolemic shock? CBC, because what am I looking for? H&H, okay. We could draw lactic acid, but they probably won't go into septic, yeah.
A CMP.
We're going to do a CMP because we want kidney function. We probably do need blood sugar and electrolytes because they're obviously very, very, okay. If this is a hemorrhagic hypovolemic shock, what other labs are you going to want to draw? H&H, for sure. Type and cross because they may need a blood transfusion. Good job. Yeah, I want your coags.
Yep.
Yeah, I do. I really do. What else might you need if you can't get their blood pressure up with the fluids and pressors?
Lab-wise?
Oh, sorry. No, just in general.
Oh.
Albumin, right? Yeah, y'all knew this.
Yeah.
Nope, was not a trick question, just straight up normal. Okay. If it is a hemorrhagic hypovolemic, what if the IV fluids are not cutting it, or you're like, dang, my hematocrit's really starting to go low, then they're probably going to need blood transfusion. Y'all just guessed or just said what the last thing I said was. So if their hematocrit, once you start giving tons of fluids, if we see their hematocrit is starting to go down, that means we're like not overhydrating them. They have too much water, right? So our options at that point, they could either get whole blood, packed red blood cells, and if it's a hemorrhagic, so they may also need they're bleeding, people.
Plasma.
Thank you. You always say that. Yeah, I can count on you. Fresh frozen plasma, which has clotting factors in it. Okay. While y'all forgot to run this lab, the patient's kidneys are failing. So now you have to put them on CRRT because you didn't check a
I said CMP.
shit. You did. Excuse me again.
Wait, hold on.
You right. So we're gonna check BUN and creatinine so we can make sure they're not going into. You right. Kidney failure. Yes. And if they are starting, I'm sorry. If they are starting to go into kidney failure, put them on CRRT. Yeah.
Yeah.
Fun.
Sure.
Good job. You saved the patient. All right. Next, cardiogenic shock. How did we get here?
Myopathy.
Heart muscles not working right. The pump, it's a crappy pump. What'd you say? Myopathies. So they could have a cardio myopathies. Okay. What else could cause a cardiogenic shock? Heart failure, severe exacerbation of heart failure. Yes. Oh, or cardiac tamponade. Why do you say it like that? I'm from Brooklyn. All right. We can also see cardiogenic shock when they're having a massive MI, right? Because that's a heart pump problem. Yeah.
Yep.
Okay. All right. I'm going to ask you up or down, and you're going to tell me this. Okay. Ready? Okay. Stroke volume.
Yeah.
That would be down because stroke volume is
Pump.
the amount that comes out per pump, and that is determined by the
Pump.
myocardium. Cardiac output obviously decreased. You're in cardiogenic shock. Ejection fraction,
Down low.
like down what? Like what?
30s.
Yeah, down in percentage, like below,
30s, 50s.
probably in the 30s, but yes, below the 50s, right? Yeah,
Yeah.
for sure. Okay. What about urine output?
It could be fine.
But probably not.
Low,
Because
low,
if you're not
low,
pumping
low.
out very much here, as soon as it pumps out of the aorta, it goes right down the abdominal aorta and right to the renal arteries. So if there's not a lot going out here, then there's not a lot going
Low.
or high, some may say. Okay. So urine output's going to be,
Low.
what's your heart rate going to be doing? That's going to be high at this point, right? It's trying to compensate.
Yes.
Oh, you're going to hate me for this. How about right atrial pressure? That's going to be high. Ah, okay. Why would their RAP be high?
Because the heart can't pump it.
The heart can't pump it out, so it's backing up into the
Right atrium.
right atrium. What about preload?
It's stretching a lot.
It is. So that would mean preload is high. The code for preload is the stretch. Since it's not pumping out, it's going to back up into the left ventricle, causing it to stretch. What about you're going to hate me bringing hemodynamics into this shit. Okay. Pulmonary artery wedge pressure.
Can it back up into the lungs?
It will be high because it's backing up fluid into the capillaries of the lungs. Yeah. Okay. Fun game. Okay. All right. You understand that part of cardiogenic shock? What do you need to do for this patient? They need fluids. They probably will need pressors. And then what are you going to do to help the heart contract better? Dobutamine. Yes, a positive inotrope. Oh, okay then. Dopamine would be a good option. What else? So you also said dobutamine, right?
Mhm.
Dobutamine, dopamine.
In the hole? The contractility?
Yeah,
Already?
you know it.
Epi?
You could give ditch, but yeah, okay, fine, you can.
Epi?
You could give epi and norepi because those do help with increasing contractility because that's part of the fight or flight. Yeah.
Yes.
All right, and you don't want this patient while that blood flow is backing up. That means that blood is just
Sitting.
so what should you probably give?
Where's the flat? So it's a color.
We're gonna give some anti-coax. Yes, probably some aspirin. Why did I say it like that? Aspirin. I don't know. I said it weird. Okay. And then usually this is going to be either surgery or something in order to fix the underlying problem. Something's going wrong, right?
Yep.
Right.
Right.
Okay. Or they may need to get an LVAD, which is a left ventricular assist device. So it's Denny. Yes. Okay. Or in patients with severe heart failure, what kind of surgery are they going to need? Really?
Huh?
And patients with severe heart failure, what surgery are they gonna need?
Heart transplant?
Yes, a heart transplant. Give him a new heart. Oh my God. Help us, Lord. Y'all were like, man, I cannot help this patient. I do not know. All right, what about a patient having a massive MI? What kind of surgery are they gonna need? A cabbage. Okay, good job, everyone. Do we understand cardiogenic shock?
Yeah.
This is a fun game. All right, let's do an obstructive shock. What does obstructive shock mean?
Something is in the way.
Something is in the way. What are the three most common causes of obstructive shock?
Pneumo.
PE,
Tension.
pneumo,
Tension pneumo.
comma, tension pneumo, and yes, could be a tumor. Oh, sorry, then there's four.
I thought that was a good one. So two would be pneumo.
Stenosis.
Stenosis. Oh, stenosis.
Oh, and stenosis. Thank you. Thank you.
Fifth one.
You know, there's 100. Okay, I don't know. Okay. What symptoms might you see of obstructive shock?
Restlessness.
No, they're not having hypoxia.
If it's a PE.
Oh, I see. Okay. Take the causes out of it. That's a good point. Take the causes out of it and just look at something is obstructing the blood flow from coming out of the heart. Okay, so they're gonna have decreased cardiac output, which means where's the blood? It's backing up, right? So they may have
JBD.
JBD. If it's a tension pneumo, what's the most common sign and symptom we see?
Unilateral.
The tracheal.
deviation.
Okay, so they do have absent breath sounds on one side, and we will have tracheal deviation to the opposite, or what we call the contralateral side. Yes?
Yes.
Okay, but signs and symptoms are going to vary depending on the underlying cause, right? If it's a PE, what's the first signs and symptoms? Restlessness and anxiety. Okay, so, okay then. All right, if the underlying cause is a tension pneumo, what's the first thing you're going to do? This is a very simple, a chest tube. Yeah,
I was like, chest tube?
yeah, a chest tube. Okay, what if it is a PE? What are you going to do? Very quick PE care. Go. What? I didn't hear what you said. I still can't hear what you're saying.
TPA.
Oh, TPA. Yes, but what are you going to do first? You know, if the patient's like having a PE, you probably ought to do something. Can you just all of a sudden be like, oh, I had this TPA thing? Yeah, how about we sit them up first? You want to set them up? Yeah, we'll set them up. Let's put them on some oxygen, shall we?
Yeah.
You want to watch the SpO2?
Yeah.
Maybe. I don't know. You want to call rapid? Yeah.
Yeah.
Yeah, we do. All right. Yeah, y'all ain't ready for this. Okay. Woo. All right. All right. Okay. Do we understand obstructive?
Yes.
Okay. There's something I was going to say really quick. Okay. Do we understand those types of shock?
Yeah.
You understand kind of what to do?
Yes.
Yeah.